Hi, everyone. I'm Hannah Wall. I'm an assistant professor of sociology at the University of California, Santa Barbara. And thank you for attending the Culture and Contemporary Life Talk series. This series is an initiative of the Culture Section of the American Sociological Association. And the purpose of the series is to explore the pressing social issues of our time through a cultural lens and examine how cultural sociology can inform these issues. So we're having panels throughout the academic year, which we encourage you to attend. And each panel will be a discussion among several speakers and a moderator, all of whom are experts in this area. The discussion will be followed by a Q&A, and to participate in the Q&A, please put your questions in the chat at any time during or after the discussion. So this session, as you know, is on vaccinations in the age of COVID. And I'll turn it over now to Margarita Rayzberg, a postdoctoral scholar at Cornell University, who will be our moderator. And Margarita can introduce the panelists and get our discussion started. Thank you.
Thank you, Hannah, and thank you also to the Culture Section for organizing this timely and important conversation. As Hannah said, I'm Margarita. I'm a postdoc at Cornell University in the Science and Technology Studies Department, and I'm here with sociologists Claire Decoteau from University of Illinois, Chicago, Lauren Mamo from San Francisco State University, and Jennifer Reich from University of Colorado, Denver. And thank you all for being here today. Each of you has written about the politics of vaccines in very different contexts. Claire, your current book project is about vaccine hesitancy among Somali immigrants in Minneapolis. Laura, your research has looked at how pharmaceutical companies produce at-risk bodies, particularly for girls and women. And Jennifer, you study how parents navigate the difficult decisions around vaccinations for their kids. And so this question is for all three of you. What does your work reveal about the role of culture in vaccine development and vaccine distribution? And Jennifer, would you like to start us off?
Sure. So first, thanks to all of you for organizing this and putting it together. I think I'm happy for all opportunities we have to connect in this strange time. And I'll say that, I started studying vaccine hesitancy. I started collecting data in 2007, and at the time, actually, no one thought it was a particularly interesting topic because I think vaccines for so long lived in the background of our lives. And I can think of, like, Laura and I started talking about the HPV vaccine as early as 2007, 2008, thinking about this as kind of new ways of talking about technologies in people's lives. Clearly, that's really different right now because we have a very different perception of disease risk. We have a very different perception of how we want pharmaceutical solutions to help us make decisions to contain risk and live the kinds of lives we want to. I think one of the things that's really important and sometimes gets erased in this conversation in terms of thinking about, what does this reveal about the production and distribution, is that for so long, I think we've really since the polio era lived in a kind of landscape where in the post-polio era, most infectious diseases were seen as solved. And that when we talked about problems with vaccine hesitancy, it was because there were something like 2,000 cases of measles in the country, which by today's standards seems really quaint, even though when there was a measles outbreak at Disneyland in 2014, it felt like a crisis. And our perceptions of disease and of risk of an infection and of the ways we make kind of informed decisions look really different. And what that's led to is a different kind of visibility about production and distribution systems. And interestingly, I think some of the inequalities we're seeing in the system now are not dramatically different than what we saw in the early days of the polio distribution also, which was that there was a scarce resource, high demand, and vast inequalities in distribution. But really what I found in my research is that a lot of the concerns around vaccines, a lot of the distrust come from the complicated relationship between for-profit pharmaceutical companies and the state as an institution of both regulation and enforcement of requirements around their use. And that's a complicated kind of relationship that has existed, I think, as a backdrop to a lot of the conversations. And I would say during the COVID era, it's come into sharp relief in ways that are really unusual, both in terms of people having the names of manufacturers of vaccines, which I can guarantee nobody could tell you who makes MMR vaccines before today, right? But we have a very different sense of the corporations. We talk about the CEOs. We know more about the FDA review process and clinical trials processes than I think Americans have been concerned with in 50 years. And it's a really different way, I think, right now of thinking about how people are interpreting science and science process and the relationship between state and capital and trying to make decisions for themselves.
Thank you. Laura or Claire, would you like to say something about the role of vaccines, the role of culture in vaccine production and distribution?
Sure, I'll jump in since Jennifer mentioned a bunch of things that I'm also been thinking about. And I just wanted to start that when I think from a science and technology studies perspective about vaccines, I think of vaccines as social technologies that do a lot of different kind of work. And one kind of work that they do is cultural work. And so I've sort of been thinking about that kind of cultural work, but it joins other kind of work like public health work, scientific work, medical work, et cetera. And a few of the things that I think are important in this era, one of them that Jennifer just mentioned is about the contextual role of biomedicine and pharmaceuticals more generally. And I think that there's kind of a paradox for me in any way, and I think in contemporary life right now in COVID, between sort of this role of biomedicine in that we've been thinking about it lately, and when I say lately, maybe the last 20 or 30 years, as a shift to vaccines being more like drugs, vaccines that are targeted to individuals, that are part of the kind of me medicine that I know Jennifer has written about this, the me medicine of biomedicine, that these are consumer products that we make choices about, that we enter into as consumers, and that this very construct and culture of biomedicine, that when we look at it through the lens right now of COVID, it's a tension, I think, between both the me and the we medicine. And really thinking about, well, how does this biomedicalization, this individualization of medicine play out now? And I do think it does, and I'm sure the panelists would probably agree in many ways. And one of the other important ways is in the ways it structures inequities or reveals and peels back. And some of these are the same long ideologies that have been present, continue to be present, and others perhaps are new categories and hierarchies of bodies and the ways that they're structurally exposed, if you will, to the inequities of social life, not necessarily the exposed to a virus, although they interconnect. So I think that that's one of the cultural ways that, or two, the power relations and the contextual factors of this 21st century biomedicine. And then I'll just end that another sort of cultural ideal that I am also struck by is Jennifer mentioned about the HPV vaccine, and that is something that I've studied at length and continue to do so. But the ways in which the vaccine itself brings in cultural ideals about gender, about sexuality, about bodies. And when I've been thinking about the Gardasil vaccine is when it asks, like, what are we guarding against? Who gets to be guarded? Who gets to be protected? And in that particular era of introduction, it's a process of a vaccine, but there was a coming off the heels of kind of gender politics and sex politics of the time, the sex ed wars, condom use debates, promiscuity of teenage girls, that really shaped it. So it's ripe to ask ourselves about what kinds of politics are particularly present now to help us. And, I'm sure at home, many of us are just so immersed in the Trump era politics of knowledge and knowledge contestation that, also linger from other periods and are not only new, but anyway, those are a few things.
Thank you, Laura.
So I'm going to comment a little bit about the role of culture and sort of understanding more like hesitancy and people's sort of responses to vaccines, because that's more what my work on vaccines has sort of focused on. And I think that, one of the things that we have saw before COVID, but I think also during COVID, was a sort of way in which the media kind of portrayed vaccine hesitancy among particular cultural groups, ethnic groups, racial groups, as being sort of homogenous and like tied into their culture. It was kind of a cultural deficit model, like this particular culture, like the Orthodox Jewish or the Somalis in Minneapolis have a particular sort of like cultural thing. And I think that that sort of does a disservice, obviously, to those communities. Because I think that beliefs around vaccines are related to one's relationship to the state, which I know we're going to talk about, one's relationship to the state and to experts and to science more generally. And that is a sort of more macro kind of approach that many people kind of share across cultural groups, I think. Though they can also be specific. But in other ways, I think people's decisions around vaccines are very context specific. So in the Somali case, for example, there are two very different kinds of expressions of vaccine hesitancy based on a series of experiences people have had with local experts, with their own doctors, with autism very specifically, because that's what the resistance in among the Somalis is about. And so I think that sometimes when we kind of paint with these broad cultural brushstrokes, which we're seeing a lot in COVID, where we're kind of saying, well, Blacks distrust vaccines, they've historically distrusted vaccines. While there's truth to the fact that there's, legitimate mistreatment of Blacks amongst, within sort of scientific history and scientific racism, that those kind of broad cultural brushstrokes are very problematic, and that we really need to unpack hesitancy, concerns, distrust as being very context specific, variable, changing over time, very related to people's experiences and relations. And I also think that there's something epistemic, and I think that's a cultural frame too, that is about this, in that for Somalis anyway, many of the reasons why they engage in vaccine hesitancy is because they believe that the ways in which they understand their own circumstances are being denied by experts. And so to them, that's an epistemic injury. It's an injury to the way that they understand the world and the way that they live in the world. And I think that that kind of component of people's sort of cultural experiences and cultural beliefs sometimes gets overlooked, I think, that there can be kind of an epistemic violence that happens to folks when they're just sort of painted with broad cultural brushstrokes, seen to be, hoodwinked by mass, social movements. So these kinds of frameworks that get used a lot in the media, I think also are experienced by many people as a form of sort of epistemic violence. And I think that that actually feeds into feelings of distrust. So those are some of the ways that culture sort of plays out in some of the work that I've done.
Thank you so much. And of course, you've connected to a number of topics that will come up in the conversation. I'd like to ask about something that's at the center of our public discourse about vaccines right now, which is how to prioritize the vaccine rollout. And of course, the most common approach countries have taken is to prioritize certain vulnerable groups, like the elderly, like frontline workers. Other groups have used other kinds of logics and other kind of criteria. But this general approach has been critiqued from a number of different angles and positions. And so what do you think about the debate about vaccine prioritization? And what does your research tell us about sort of the possible models and logics of distribution that are available, but that we're not seeing in this moment? Laura, would you like to start?
It's not, well, I might defer to someone else, but I guess I will say that the rollout for me, just from my perspective, has just revealed the fragmentations, and maybe we're getting into kind of the state and the state type actors and the roles that people have. But the contestations at the intermediary actor level are local and regional and national public health departments, the CDC, as well as healthcare organizations, private ones, public ones, and who has access to healthcare in general. I mean, all of the complex politics around healthcare distribution is playing out here. And also the complex issues around these organizational actors and the ways in which we have privatized so much that the strength of the public sphere, or what what we may have thought about as state actors, like even the CDC and the WHO, although they've done remarkable jobs in many ways. The rollout to me is exemplary of this fragmentation and many of these issues.
Thank you, Laura.
Mm-hmm.
I mean, I can jump in on prioritization because I think I've watched now like every ACIP and FDA review committee meeting. And because it's like to get in the weeds is where you really hear what the cultural arguments are about. And, you know, one of the things just as background is, you know, it's worth acknowledging that the 3 vaccines available right now, none have been fully licensed. And they are all authorized under an emergency use authorization that became available in a post 9/11 world where there was a fear of bioterrorism, right? So it was always intended as a state tool to bypass certain kinds of regulation. And so when people raise questions about that, I think those are fair questions that we should be having conversations about. That's not to say that the clinical trials aren't powerful in number of participants or that the data are not solid, right? But to say that the usual regulatory processes have been leapfrogged in certain places. Mm-hmm. And that if you are interested, like you can stream these meetings because they go through real-time safety data, real-time as they're learning it data, which I think is really compelling. And I'll say that having studied vaccines, the one thing I will say is that they are better monitored after licensing than any other pharmaceutical product we have. And there's a lot of things to say about that that are important. What I'll say about the prioritization then is that it was really interesting to watch a room of medical doctors and researchers argue about something that at core was social, not medical. So their argument was, how do we prioritize a scarce resource? And they said very clearly that they felt they had 2 goals. One was to save lives and limit, you know, morbidity and mortality, and the other was to preserve social functioning. And by virtue of defining those as 2 goals, they automatically identified 2 totally different subpopulations. And then in that process, we're very explicit that they would not make a race-specific kind of recommendation. And therefore, it was going to be a colorblind recommendation, which would fail to acknowledge that the risk of morbidity and mortality is not equally distributed across populations or communities, and that the kinds of vulnerabilities are not either, right? So that as a starting place, they already said, we're going with this formal equality perspective. And they're, in my opinion, I know these members, a lot of them, I respect them tremendously for their areas of expertise, but they're not, this is outside their lane, right? Like making these kinds of social determinations. And so, you know, automatically it seemed like, okay, those are 2 self-explanatory goals. And if we drill into those, what we find is that they're really not. So when we said that there's vulnerable populations, it's really hard to say vulnerable to what. And the tension in that we have, that it remains unresolved across the country. And I'll just say that at this point, I think only 3 states are still following CDC recommendations on prioritization. There was a very quick movement away from the federal recommendations. Or when we say risky, we haven't really agreed if it's risk of bad outcomes of infection or if it's risk of exposure that can lead to infection. And so if we can't even, if we don't have a common vocabulary of what risk we're protecting against, then we have a really hard time making priorities make sense. Similarly, if we say that there's essential workers, those have been defined by industries, not positions, and not exposures, right? And thinking about that. So when you really then look at what does that mean in terms of how does that get implemented on the ground level, what you'll see really quickly is if you look at the Operation Warp Speed map of their plan, there is quite literally a picture of an airplane and then a list of constituencies who need vaccines. And there is no linkage between the airplane and the constituents. And that was on the graphic that was publicly distributed, which just marks the way that there was no imagination for what it takes on the ground to reach actual people in actual places. And so what we did nationally as our national explicit strategy was we doubled down on large corporations and ignored the fact that the majority of healthcare doesn't serve people, right? It's not best served by large corporations. And so unsurprisingly, the rollout with CVS and Walgreens, which is a federally direct contract, has not succeeded in reaching people effectively. And then we know that if you were already well served by large healthcare systems, it worked pretty well for you. And if you were already outside of those systems, whether it's because you're a healthcare worker who works for a small hospice agency and not for a large hospital corporation, you were missed as an essential worker in the early rollouts, right? Like to think about the ways your relationship to those organizational strategies shaped that is a different question than how the prioritizations, which were set in ways that were almost impossible to actualize, then further illustrates what Laura is talking about, right? Which is that defunding of the public in public health and translating it into those sort of corporate neoliberal partnerships made it impossible for this to in any way, like it was designed to fail. It was designed to magnify the inequality we already had, and therefore that's what's happened.
Yeah. Thank you, Jennifer. Claire?
Yeah, I'll just talk a little bit again about sort of the reception of all of this. So I've started doing some research on COVID with three vulnerable neighborhoods. And so it's not just about vaccines, it's about sort of people's broader precarity since March of 2020. But when we do talk about vaccines, there's a couple things that happen. So I think that like many major cities in the rest of the country, Chicago's initial map of distribution was, categorically white and middle class was who was getting the vaccines. And that was true for health workers, and that was true for the elderly. And there was a lot of pushback from the city saying, oh, well, that just has to do with where the health workers live and that they're white. And then there was pushback from communities saying, but not all health workers are white, like especially in Chicago, that's totally wrong. So anyway, so there's been a lot of conversation and pushback. And in talking to actual residents about their, whether they want to get the vaccine, how they feel about the vaccine, many of them bring up both the unequal distribution as a concern of theirs, saying that it kind of reveals to them that, the state once again has disinvested from their communities, which to them is another reason to sort of distrust the whole process. And then at the same time, many of them do have concerns about the fact that it was developed under Trump. So for many Black residents in particular, we're saying, this is a racist white supremacist person, and the vaccine was developed underneath him. So I don't know. I mean, I have to kind of wait and see. Wait and see is like a big thing that's emerged a lot amongst people, in Latinx and Black communities as well. So I just wanted to mention that I think that it's interesting that both the unequal distribution as well as the sort of just who under whose face the sort of vaccine was initially developed has a lot of meaning and import to folks who are trying to decide what they're going to do. So,
and one thing I would add to Claire's, this is the thing I've been thinking the most about, is that so one, that I think like unequal distribution fuels distrust in public health systems, right? Which makes it harder to have these conversations. But also, I think we're going to approach a tipping point this summer where we will have enough vaccine supply for everyone who wants one, which is a different problem than we have right now. And then we have this other problem, which is how has the inequality sewn into the beginning of the distribution will lead to fewer people being interested on the back end. And that these two, they sound like two totally different problems, but they're really closely tied together, in part because knowing someone who's received a vaccine is a really good predictor of who wants one, and how we understand who these are for, who these technologies are for, and who they're safe for, and how they're, right, is tied to who we know. And because of the significant disparities in the initial rollout, it's really clear that there are vast differences in who knows somebody. Like if you have an income over $90,000, less than 10% of people don't know anyone who's gotten a COVID vaccine. And if you're under 40,000, that number is 2, 3, 4 times higher, right? And then all of a sudden your perceptions of information, of systems, of technologies, of safety, right, look totally different because of the way that initial rollout was structured, that I think will be amplified and magnified over time.
Jennifer, I'm glad you brought that up, because one thing I've been thinking is the trajectory of this vaccine and the rollout is, it's so much shorter in so many ways. I mean, it relied on knowledge that was already in place around the SARS. And so there's just so many issues that sped it up. And so the very issue that you're talking about, we see these rates that, people are saying there's hesitancy in various different communities, but they're closing also fairly well. The data that I've looked at from DC or other places seems to be closing pretty rapidly, that it's not, it's not something about cultural groups and difference necessarily, but is about what you just mentioned, that it is about the trajectory, and that the same sort of inequalities and exposures at the beginning are shaping where we land. And so I'm struck by the speed of that. And you said it'll be interesting to see where we are in the summer, right? Which is only it's not 15 years from now. I mean, when I've looked at other vaccines, the people study the rates and hesitancy over 5-year periods, 10-year periods, and this is so different.
And this is one of those few projects where I'm constantly I'm like, oh my gosh, those data are all the way from December. They're useless. Like, when would we have said that about opinion poll data? And it feels that way, right? In real time, people are changing minds. The thing that I see, and I don't know, Claire, what it looks like in Chicago, but what it looks to me like on some of the national data are that there's not a huge disparity in who says they never want the vaccine, but the wait and see, that question of like, I don't want it yet, has a big difference amongst Black and Hispanic respondents. And to me, that's totally logical. Because when you look at why, some of it is information that should be solved, like, I don't want to have to pay for it, or I'm worried I'll have to pay for it. But a lot of the answers are things like, I don't want to miss a day of wages if I have side effects. And that's not irrational. That's not a conspiracy theory, right? That's about making informed choices with where you are and the social structures you have around you. And so that, like, when we talk about really what we mean by hesitancy, that is, to me, like, that zone right there is what we're going to be talking about, I think, moving forward, because the private sector hasn't done anything to equalize this for workers. We haven't done anything at the public policy level to advocate for people. And those are, I think, significant sources of hesitancy besides I don't trust, right? Which I think we sometimes overplay the sense of trust, distrust, and underestimate structural barriers to things.
Thank you all so much. And this is actually a great segue. I mean, I had a number of questions about the state, but I do want to dig into some of the things you were just talking about in terms of how we interpret vaccine hesitancy on the part of different communities and how we make sense of that and what tools sociology and sociology of culture has to make sense of this. And, so we've talked about how, for example, in the Somali community that Claire studies, and also the communities Jennifer, you and Laura have mentioned, of course, they're skeptical and distrustful of the state because of historical trauma and ongoing marginalization and this feeling, I think, Claire, you write about as kind of not being part of the social compact and therefore, having all kinds of concerns. And of course, but we also see groups in the US who are afraid of the state overstepping when it comes to civil liberties. Because we're a group of sociologists, I would like to read this quote by Jin Young Kim, because it so well expresses, I think, the kind of the source of this mistrust in this other part of our population. And he writes, or he says, the mistrust in public health is well-founded. There is a controlling aspect of public health. As a physician, I put tuberculosis patients in a lockup facility in Boston, Massachusetts if they refused to take their medication. The law gave me the right to do this because that person would be a risk to others. These laws do exist, and the notion that public health is going to come in and take over your life is real. So here is someone who's a medical professional of, really sort of high expert levels, acknowledging, right, that it is within the medical systems, there is that possibility. And so I'm wondering, what do you see as the relationships between these two distinct and somewhat parallel conversations about how we interpret hesitation, how we interpret distrust of the state, in groups that seem really with very different historical trajectories, of course. So is it the same? Is it different? Thank you.
Well, I know Jennifer's written directly on this topic, so I won't take too much time, but I think that, obviously vaccines are a biopolitical project, right? They are about the protection of the population. And so as I've already mentioned, so whether or not you see the state as a sort of legitimate power and you feel included within the sort of body politic and protected by that body politic, then you're more likely to probably buy into the sort of notions of herd immunity and things like that. And I think that that's one thing that I see sort of, that I argue, is one of the things that Somalis are contending with, is the fact that they don't feel included in the body politic. They feel extremely excluded. And they feel, and you can see this with, anyone who sort of experiences state violence, high maternal mortality rates, environmental injustice would be, less likely to sort of believe that the state has their interests at heart. And therefore it's less likely for one to sort of buy into this kind of biopolitical kind of inclusion, because you're not included. And I think that's, again, like at that kind of structural level and people's sort of understanding of the state, and that's certainly important. But I also think that the sort of experiential level and kind of relational level of people's experiences with doctors, with experts in their communities, with each other, with their own community members is also really important. I think sometimes we miss that component because we like to sort of talk about things in these big ways, but I actually think also, hesitancy is about these experiences and these relationships and these kind of community levels of knowledge and trust. And so I think in that sense, these two groups are very, very different, right? So on the one hand, they sort of share this kind of understanding of the state and vaccines as a biopolitical project, and they understand like what that is sort of means. And I'm sure Jennifer will talk more about like the history of biosurveillance maybe, which is clearly where that quote is kind of stemming from. But, anyway, I just think that but that's missing the fact that a lot of people's hesitancy and it could be a variety of forms of hesitancy, right? It might just be delaying for a little while until one kind of sees, like that happens with Somalis a lot where they're so concerned about autism. So they wait until their child speaks and then they give them the MMR, but they give them all their other vaccines. So they're not opposed to vaccination. They're just really, really worried about autism specifically. So like, that's a very specific kind of concern, which I think we're also seeing a little bit with COVID. People, as we've already talked about, sort of waiting to see. They're not opposed to vaccination. They're just a little nervous about what this all means and how it's all going to play out, which again is pretty practical in some instances. So I think if you think about it as being sort of both levels are really important to attend to, then then the kind of relationship between those beliefs is different. So
Jennifer or Laura, would you like to add or respond?
I mean, the way I've been thinking a lot about this, I think we're so accustomed to thinking of public health as a thing that still exists. I actually don't know that we have a public health anymore. And that maybe I don't tell the people at my university who do public health because we have like this attachment to the idea, but public health a long time ago relinquished its role for the public, right? And it became an industry of personal behavior modification and of promoting health behavior models rather than community solutions or solving environmental pollution or the things we really need public for. The thing I'm currently losing sleep over, the thing I think about every day now is the way we filled the public part of public health is with private corporations. And I think what I think is coming that we have to start thinking about is what do we do very, very soon when the private sector and private corporations take ownership of public health in ways where they start enacting requirements for vaccines, or they make vaccination a condition for employment or for travel or for participation in civil society. And the reason I worry about this is not because I'm opposed to vaccines, it's because the private sector is notoriously bad at medical privacy. It's notoriously bad at religious freedom, unless it's a very particular brand of religious freedom that makes it to the Supreme Court. Unless it's the religious freedom of the corporation, not the workers, I should say. And it's bad at pregnancy protections. It's bad at the ways that workers need advocacy. And so it doesn't take a lot of imagination for me right now to picture the grocery store chain that wants to advertise that 100% of their workers are vaccinated, so you shop there. Or the workforces that start to see that the vaccinating of their workforce will either lower their medical premiums or will protect them from some kind of liability risk. And thinking about that these are not necessarily altruistic public in the way that we need public health to work, but they're going to be driven by corporate interests. And those almost never work for the good of the workers. And those are the things now that I'm worrying a lot about because even if we just take things, I think I just looked at some survey data to say that right now, 8 or 9% of this one survey of about 1,800 CEOs that they plan to require vaccines, but 43% said they're not sure. And if you look at why they're not sure how to handle pregnancy disclosures. They're not sure how to handle pre-existing medical conditions. And that it's really that fear of liability that's holding them from figuring out how to do this. It's not an unwillingness. And so when we start to think about what this means, we may have a system where the public entities step in and offer guidance, but it's going to play in two totally different opposing ways. So like the New York Bar Association said that they want to protect employers who want to mandate vaccines. And I'll say here in Colorado last week, there was a new bill introduced to protect people from discrimination in the workplace because of vaccine status. And both of those kinds of legal responses have problems built into it, but they illustrate the relinquishment of the public sector in actually creating and monitoring and managing solutions that protect people. And so I think when we talk about public health and the cultures of public health, I think we also have to start to think about where we've relinquished the public part of public health and really ceded control in ways that I think are going to be harmful.
Yeah. I'm glad you brought that up. I think that I share some of that lack of sleep with you. And I was reminded of it. I think today, this morning, was released the ad campaign by the Ad Council that was, a multi-private sector, public sector partnership to, encourage people that it's up to you to get vaccinated, and really using not too much different language from when it's like pharmaceutical companies driving the consumer message of, this is up to you to protect you and your health, and you need to be the self-empowered actor to, to act in your own interests, perhaps the interest of the public. But that message, it's brought to us by, Facebook and Adobe and other big companies that aren't even, my concern has been public health becoming, pharmaceutical companies taking on the role of public health information and education. But here it's Facebook and Adobe systems and other tech companies, right, taking on the role of health information and joining this. And many of those issues that you gave as examples, I think, are right to dig deep into and see where they might be headed. So thanks for that.
What are the sources of information that the groups that you all study are using, and how do they determine how to trust different sources of information, and what are the kind of legitimate sources of expertise that that they turn to in thinking about vaccination? Claire, Jennifer, or Laura?
I think that maybe, my research lately has really been mostly talking with scientists around the cancer prevention and cervical cancer prevention. And I'll only bring it up briefly to say that those scientists are really thinking more in terms of biomedical culture and models. And it's related to COVID in the sense that they're thinking about how vaccination fits in with other technologies that are also just as social, like screening technologies and testing technologies. And of course, COVID, test, screen, is also part of this vaccination conversation, and the ways that access to testing, being able to know contact tracing and all these other things follow many of these same paths. You asked, where do they get information from? I don't think I'm answering that. I think what I'm answering is the kinds of people I've been talking with lately are these scientists and healthcare providers, from kind of pediatricians up to oncologists, who are thinking about how vaccination is one component in kind of an apparatus of preventive tools.
Yeah, I've had a similar experience. I've started doing some interviews with Chicago Department of Public Health employees, and they invested all of this money into the infrastructure of contact tracing. Huge amount of money of the CARES Act went into this whole infrastructure, new technologies, all this kind of stuff. And then they found that even at the best, they could get like 30% of people's contacts. And so what they've done is the way they talk about it is that they're now using all of that infrastructure and all the people that they train to do vaccine information campaigns. Well, that's not going to be the best way to do vaccine information distribution, because you got some person from the city calling you to ask you about your sort of contacts, and people are very distrustful of the contact tracers. And so even if they're trying to hire people from the community and things like that, but it's still like a contact tracer calling you from the city. And so I just think that's a really poor plan. I mean, I get that they built all of this infrastructure and spent all of this money and they want to use it. And so I get that the impulse is sort of like good maybe, but it's just, I just don't think that that's going to be a really effective strategy. And one of the things I was thinking about when Jennifer was talking about, you know, the fact that same thing that I've been finding from folks in Chicago, that a lot of what I'm hearing is, well, I'm just going to wait and see. I'm going to wait and see until the more people that I know, you know, don't have really bad side effects and that it's gone okay. I'm sort of waiting to see. This kind of waiting to see idea is, as Jennifer was saying, is very reliant on sort of your networks. But I've also been thinking a lot about how the ways in which COVID has really fragmented networks, not just in the sort of like social isolationist way, but also in the fact that like, just because people are so precarious. I mean, in some communities, they've bonded together and tried to find ways to sort of survive for sure. But there's also been cutoffs on particular benefits. There's been, you know, like ICE raids and things like this. And so this cuts people's social kind of networks and really fragments them. And I think also contributes to, you know, distrust. And so you have all of these fragmenting policies, fragmenting sort of processes that might get in the way of people sort of building on like their relations as a form of sort of building trust in vaccines. So that's just two things I was kind of thinking about as we've been talking.
It's interesting because what I would add is that, you know, I mean, there's good data to say that people still overwhelmingly see pediatricians or doctors as good source of vaccine information. And it's a separate conversation to say like how well those folks are really prepared to have hard conversations, particularly around COVID. But you know, so they are a source. But what I found in talking to parents who reject childhood vaccines is that they saw them as one source amongst many, and that we really culturally have moved away from an experience of healthcare where people take their doctor's advice and go do exactly what they're told, right? And I don't know if that ever happened, but we know generationally there was more deference to the institution of medicine. And that's really fragmented in ways that have been really important. I mean, we think about the women's health movement. We can think about lots of HIV activism, right? We can think about lots of places where that fragmentation has been good for really breaking down some of the structures of knowledge that have increased inequality. And so it's not to be dismissive of those systems, right? But there's no longer like a sole source of information. The challenge with medical systems is that I think, and it sounds like this is what you're finding also in both of you, you know, in your research, is that there really is still this predisposition to believing that if only people had information, they would make the same choice that medical providers want them to make. And when I work with a lot of, you know, I work with a lot of physician researchers, and they really all want to build like an app to educate people, right? And we're still really attached to this sort of medical information model of decision making, which we know doesn't make any sense. You know, and I keep thinking like we would have things like no ice cream purchases or perfect condom use, right? Like if it was just a matter of what you know, we would see different kinds of health outcomes. So we know that's not what drives decision making. So then what's happened, I think, with initiatives like the Ad Council's very well researched campaign is this idea then it's like, well, what resonates? Well, that we've really, this individualism, right? This like, this notion of personalization and individualism has been the centerpiece of the way we talk about health promotion. And so let's double down on that. And that's really, I think that the tension is like, you know, we should absolutely combat misinformation and disinformation. I think that's important. People should know they can get a vaccine for free, or they should know how to access it, or that it doesn't take a credit. Like there's lots of things that are misinformation that should be dealt with, but that's low hanging fruit. After that, the idea is just that it's irrational not to follow medical advice. And, you know, to Claire's, I think Claire's case is a perfect example of that, which is like, but somebody called you and offered to help. Why would you not take them up on it? It seems irrational if you're a true believer. And to be fair, medical providers have really not spent a lot of time questioning the logic of vaccines because they've been relatively stable for so long. We do know there's a generational divide, like younger doctors are more flexible around vaccines than our older doctors. We know that there's some differences, but in general, right, the medical model of like rational decision-making based on information, which everyone's so attached to, I think has been the way that the tool has been moved forward. And so what we're seeing is like, can't Fauci make another video, right? Can't we have another white coat person tell you what to do and then it'll be fine? And we just know that that is a source of information, but it's not a unifying source of credible information as people experience their networks, as they experience their priorities in their lives.
Yeah, I think what's interesting about what you said about the doubling down on that personal information, it does align in a nice close affinity with doubling down on capital in general, and doubling down. I know that you mentioned the apps, and just if we could just create another way of getting health information. In terms of the relationship between vaccination and screening, COVID has done so much to, push industry into like offering more and more things, to buy that comes right to your house, like screen at home, just take care of understanding your molecular risk to, sure, COVID, but every other thing, HPV, other molecular disease, through this same personal self consumer-oriented model, that then the result will lead to the place where we know it might lead, which is we actually need, infrastructure and organizations that can provide care. Maybe not healthcare and medicine as we currently have it, but we certainly don't have the care structures set up.
Well, and there's such inequality in who accesses those technological services as well. So that's a huge part of it too.
Right.
And I think the distinction between coming back to this idea of risk, right? That if you have we don't really know what a pre-existing condition really means. We know there's correlates to severity of illness. That's it. That's all we've got. And so how those get used, that like the screening is somehow a treatment. We've really confused that culturally prior to COVID. And I think you're right to say like that even the home testing for COVID kits, right? Or the increased testing of COVID, and the way we don't even know how that information will get used. We don't know how COVID will be treated long-term in health systems, right? Will this become a pre-existing condition again? Like there's a lot of questions about those data that are being generated too. But that screening, is not treatment or care.
No.
So it is now, we're on to the Q&A portion of our session. So I have a few questions here from the audience, and they all connect to some things we've discussed, which is great. So Ashley Bowen asks, or says, I'm a historian by training, not a sociologist, so forgive me if this question is too historical, but Ashley is wondering about how the COVID vaccines are described as a consumer good, and how the language of choice plays into a culture and where we think about ourselves as consumers of health, or consumers of health or information interventions.
Well, I think if we're thinking about vaccines, a historical shift around vaccines that's important is that, we thought of vaccines as things that were developed for highly contagious, like COVID, but anyway, for highly contagious illnesses that were, devastating and deadly, and have largely affected children, were many of the vaccines that were sort of brought forward as kind of miracles of public health, and had this narrative and face that we associate with vaccination. But gradually there was changes among kind of pharmaceutical development of vaccination, and some of it had to do with sort of scientific knowledge and capacity, but other had to do with markets, and also really thinking about patents and markets, and how to develop vaccines for non-life-threatening conditions, and conditions that were not affecting everybody per se. And so the language and ideology of consumerism and individualism that we didn't see in vaccinations, but we did see in drugs and pharmaceutical drugs. If we think of, drugs for cholesterol or Viagra, for other, that are advertised as products. So we did see a shift, and it had a lot to do also with regulation, deregulation, I should say, not regulation, but changes, particularly in the US, and then certainly not everywhere, around being able to advertise products kind of directly to consumers and in other ways. Some of it from my viewpoint.
I think looking historically, So, we really had very few vaccines prior to the 1960s, right? There was smallpox, there was diphtheria, and then polio. And polio was part of a national race that was driven by what became the March of Dimes. There was a sense of collective funding that created a sense of community solution. And it was 1954 was a pandemic year, and it affected children. I think we can all agree if COVID was a disease of children and not older people, this would be a different conversation. So there was a sense of a national solution was needed, and there was a huge buy-in, and there was a juncture between the nonprofit sector and the federal government in sort of creating this framework for it. But there were also 30 or so manufacturers who were willing to make the polio vaccine.
Right, yeah.
And so there was a very different kind of market landscape. And I know the urban legend is that Salk said you can't patent the sun. Of course, there's no patent on the polio vaccine. There's historic record to say he tried to patent it and failed. But that is our legend of vaccine. So the heritage of the vaccine is that it's the people's vaccine. And then that starts to change through the 1960s when Merck really starts to build the infrastructure for new vaccines, for measles, for mumps, for other kinds of diseases. And it's still part of that, I think, American progress story, like science will save us, antibiotics saved us in the 1950s, right? Like we have that story that breaks down in the 1980s. And that from like the folks I study in terms of sort of the modern opponents of vaccines are really driven by this moment where parents were witnessing things in their homes, like children developing seizures or having permanent brain damage or death that they believed was caused by the wholesale pertussis vaccine. And because of some combination, I think, of other health social movements that had happened in the 1970s that had laid the groundwork for speaking back to medicine in a way that hadn't existed, along with some media coverage that allowed people to find each other, there was really a change starting in the 1980s. And what's important about that is it gave people a vocabulary and an opportunity to start questioning medicine in a way that vaccine researchers I've interviewed have said they were ill prepared for, that they did not see this coming. They had no vocabulary for talking to the public, because until then they had postage stamps and parades in their honor for saving humanity, right? And they were totally ill-equipped. And there's no way that vaccines, it's not that there's a vaccine exceptionalism. I think we think about like vaccine refusalism, how different than other kinds of things. But it really is overlaid, I think, on all these other ways of questioning the systems of healthcare, the systems of medical domination, the systems of pharmaceuticalization that were taking hold at that same time period. That led then to this becoming, you should be an informed consumer, in the same way that I think the women's health movement really pushed forward. And therefore, now we don't have community solutions, we have individual ones in the ways that I think Laura is highlighting. And so that's, it's sort of, I think, a paradigmatic change in how we think of risk and prevention that changed at that moment, but it changed through social activism in ways that led to the change of the vaccine, that led to a different vaccine that's much, much safer. So it's not that it's totally, it was just like spinning noise, but it actually mattered in terms of people's lived experiences of their children's health.
Claire, would you like to add anything?
No, I'll just say that, I mean, it's often seen as like, thinking of vaccines as a choice that you have to deliberate upon and do a lot of research on is often seen as, I mean, just like Jennifer was saying, as an anomaly, when in fact, it's just part of the people's entire approach to medicine now, which is all about sort of, you do your, or even approach to parenting, right? So you do all of your research before you decide what, sleep strategy you're going to use with your kids. So why wouldn't you do the same thing with vaccines, right? So, I mean, I think it's just, vaccines are often held up as some sort of anomaly to, a process that's been going on, as Jennifer was saying, since the 70s. So in our approach to medicine and science more generally.
Thank you. Another question, this is from Adrian Hall, and this shifts us a little bit into the global sort of questions around vaccination. We've talked mostly about the US. And Adrian is wondering what your thoughts are about the global politics of COVID-19 vaccine distribution, and maybe questions here linked to vaccine diplomacy on the part of countries that are not necessarily the strongest players in geopolitics, which is very interesting, of course, and how we might think about the US model, maybe US model of thinking about vaccines or making vaccines in relation to other places and other models. So big question to end on.
Yeah, I think it's really interesting because I think that in some ways, at the distribution of infection of COVID, people were very surprised about, for example, that most countries in Africa didn't have as high of infection and death rates as a lot of Western countries. And of course, that's, not true across the board, but, and in places like South Africa, of course, which also has massive amounts of history of racial apartheid, it's also very concentrated in particularly poor and Black communities. But I think that what is not surprising is what we're seeing with vaccine distribution globally, which is that, it's the same old story as it was with, antiretrovirals and other efforts to get, medical technologies that are produced in Western countries to countries in the global South. I think what is different and will be kind of interesting to see is that there is a lot more capacity for the production of generic technology. And so perhaps that will, kind of change dynamics. But I think that it's possible that given this, global infrastructure that we have and the inequalities within it, that, COVID will have much longer term effects on countries in the global South, both in terms of being able to sort of get a handle on the illness through vaccination, but also in terms of just economic fallout. So I think that the precarity around these will really play out in the coming years. I actually think similar dynamics will play out within countries as well, that we're going to have some long-term structural inequality effects of everything that's happening now.
Yeah, thank you. And I'll just add, hello, Adrienne Hall. And I do think that it's important to sort of put this conversation into a geo-biopolitical project, because, the vaccine rollout, but also much of the sort of cultural workings of vaccination has so much to do with the ways in which the COVID pandemic has been so geopolitical and terms of the kind of racism and xenophobia and other structural inequities that have happened. But one thing that I'll just kind of end on is that I've been thinking about is that the pharmaceutical kind of company R&D has often been talked about as kind of developing drugs for the kind of 10% who can sort of most afford them, or to reap the kind of benefits of the 10%, and then but the vaccine or the product works for the 90%, and how does that model work in this kind of COVID context, or really in any kind of epidemic context? I think is a question that will need to be answered by someone else. Thanks for the question.
And I'll just, I think, to link these two last questions, Operation Warp Speed was a ton of government money given to pharmaceutical companies to develop work. And so what we learned is that if you fully fund science, you get results. That's really helpful to know. And that should be a model for moving more funding towards science in the future. But it was also a lost opportunity. We had a public investment in a solution that should have felt like people had ownership of these products, and that hasn't been people's perceptions of their rollout. And that's unfortunate because we paid for this science, we paid for these products, and we prepaid for all these vaccines. They're not free. We've all paid for them already. And so the fact that there's a perception problem, I think it was a lost opportunity to use this in a different kind of framework, and we didn't have the leadership to do that. In terms of thinking about global distribution of vaccines, it's not just about COVID. We've had, Gavi does their part to sort of make vaccines affordable for childhood vaccines. And we also know that in years when there's market demand to countries that can pay, they've pulled them out of, like markets pulled vaccines out of the alliance to make them available to the private sector. So it's sort of a second tier thing. What I worry about in the COVID vaccine thing, is twofold. So I guess there's multiple folds, there's a million things I worry about, but the COVAX alliance to try to create global access, the US initially was not going to participate. That's a problem in terms of thinking about whether countries are in competition for purchasing or not. And then what I worry about more in the US, because I think about it more in the US, but I think it's a global question, is the idea that certain vaccines are intended for certain people or certain countries, and the ways that lack of infrastructure have been used to justify other kinds of products. Like, well, there's no cold chain. In the US, the way I think about it is the arguments where I live that we shouldn't be giving any of the mRNA vaccines to people who are unhoused because they might not show up for the second dose, despite no evidence that compliance is lower amongst people who are unhoused, right? But this logic that certain people can't handle certain technologies I think is concerning. And we're seeing that, I think, in the distribution conversations around the global south, around other countries. Having said all of that, I was shocked to learn that vaccine hesitancy is a global problem. The World Health Organization named it one of their top 10 public health issues in 2019 prior to COVID, and that I had imagined countries with good social safety nets and public health systems would have less vaccine hesitancy, and that's not true. Countries, the Netherlands, France, the UK, Germany have all seen the same kinds of distrust. And a lot of that comes back to the relationships between the state and the pharmaceutical companies that people don't feel are transparent enough and don't feel trusting enough in those processes. So even outside of the American context of hyper privatization of public health, a lot of the same themes I was disappointed to discover have traveled really well across the world, because those nexuses, the nexus of that state and capital piece have been problematic and have been considered really opaque to understand from the outside. And I think that moving forward, how these vaccines, when they become licensed, if they're patented, if there's going to become a shift where how they get funded becomes privatized, all of these things I think are really going to matter, fast forwarding to the transition from pandemic to endemic, to a virus we live with in manageable, hopefully, ways.
Thank you, Jennifer. Claire, would you like to add anything on the sort of global distribution or global concerns?
Oh, I already answered that question. I will just say though that the concern about cold storage or people coming back is obviously not a new one, because with antiretrovirals, that was like a huge thing. That was part, like, people don't wear watches, so they can't take antiretrovirals, right? So that's been a constant sort of excuse for not, supporting global distribution. So it's an ongoing story. Anyway, I'll just add that little.
Like that people can't be good managers of risk in their own lives, right? Because of structural inequality has a perverse logic to it, for sure.
Well, we're out of time, and I just want to thank each of you for this great conversation, really thought-provoking, for your thoughtful answers, and for opening up so many new questions. I'm going to turn it back over to Hannah. She's going to make some concluding remarks. And thank you very much. This was really great.
Yes, thank you so much, Margarita, and thank you to all of the panelists for that really fascinating and timely discussion. And I just wanted to say to everyone, please stay tuned for our next Culture and Contemporary Life series panel. It's called Creative Industries in Crisis. It's on how creative industries are being reshaped by the pandemic. And this will be on April 20th at 2 p.m. Eastern Standard Time. The speakers will be Patricia Banks, Stephen Tepper, Angel Christin, and the moderator will be Rachel Skaggs. So thank you everyone for coming, and have a great day. Bye.